weaning for ECMO happens once the lung compliance improves. So essentially, once we see that there is adequate tidal volume being delivered on the ventilator, we decrease the FiO2, or what's called the FDO2, on the gas cylinder for the machine. So essentially, we are trying to assess how much oxygenation the lungs can take. Also, we decrease the sweep gas flow and look at the CO2 clearance. And this is assessed by doing ABGs for the patient and also looking at the clinical condition of the patient. So if you decrease the sweep gas flow and the patient starts hyperventilating, probably his lungs are not able to transfer CO2 across, which is why he's feeling breathless. So you go back on to ECMO. So this was the patient 2 weeks after on the ECMO. So essentially, his lungs have opened up. And we've got the patient's FiO2 down to 40%, and he's on pressure support ventilation, right? So now we have to take ECMO, this patient off ECMO. So once we know that the patient is on adequate oxygen supports of 40-50%, his CO2 clearance is adequate, what we do is we turn the sweep gas flow off to 0. So what this essentially means is the blood flow is still there through the circuit, but because there's no gas flow across the circuit, there is no gas exchange happening. So it's just extra volume which is going through the circuit. Nothing is happening. So once this is done, then we keep it like this for about 24 hours to make sure that the patient is comfortable of being off ECMO. So once we know that the patient is comfortable and the blood gases are fine and he's not distressed, he's not having a high minute ventilation on the vent, what we do is we decannulate. So venous decannulation, we do it bedside in the ICU, essentially. So we do put skin sutures and pressures on the vein while we decannulate. And there's usually no complication. Once we decannulate the patient, 6 to 12 hours later, we do a venous Doppler to look for presence of any thrombus in the vein. And if there is a thrombus, we start them on therapeutic anticoagulation. And then we continue weaning from the ventilator. And almost all of these patients require tracheostomy because they're usually there between 10 days to up to a month on the ECMO. So their weaning takes a long time. So it's good if we can do a tracheostomy in these patients. The other part of it is mobilization on ECMO. So once the patient is ready to wean, you have to start physiotherapy for these patients. So you start doing passive physiotherapy, and then sometimes you can get patients to even walk on ECMO. And these both are videos from outside. We don't do this. You need a lot of staff to do this safely. So you can even have patients playing basketball on ECMO. And then you can even take the patients out of the hospital. So this is something that I had done while in London. So this patient is on ECMO, and this is the River Thames, and this is the British Parliament. So we had taken this patient out of the hospital to just have some time out of the hospital. So essentially, ECMO is a complicated therapy which pushes the limits of human physiology. It needs specialized training and teamwork. It needs understanding of the machine and its interaction with the body physiology. And anticoagulation is a major intervention that needs to be worked on. Okay. So that's the end of my presentation.